Okay, good afternoon to everyone. Again, thank you for joining the National Center for Primary Care Annual Conference today. We have a great panel for you, so I want to welcome you to our session, Faces of Primary Care, the intersection of primary care, innovation, and culture. So we agree we're not going to spend much time trying to introduce our illustrious guest. That would take a while, but what we're going to do is they're each going to introduce themselves, their organizations, and kind of spend some time talking about their strategic vision for the first 5 to 7 minutes each. And then we'll have a few questions for the panelists, and then we'll open it up to questions for you. And we invite you all to put your questions in the chat anytime during the presentations. Please put your questions in the chat. We welcome them and we look forward to reading them. So briefly, I'll introduce our guests for today in the order that they will present. First, we have Ms. Nora Hernandez. She's a proposal development manager at the University of Texas, El Paso. Then we have Ms. Sheri Daniels. She's the executive director of Papa Oga Lakahi in the Hawaiian Islands. And then we have Mr. Silas Buchanan. He's the CEO of Our Health Ministries in Cleveland, Ohio. Now, they have multiple titles, so I'm just telling you one of them. They can tell you about the rest. But anyway, I want to go ahead and turn it over to Nora to get started, and you all can share your screens as needed.
Well, happy Wednesday, everyone. Un feliz miércoles a todos y todas. Mil gracias. Thank you for the opportunity to participate in this panel conversation and to share the space with these amazing presenters that are doing some incredible work. My name is Nora Hernandez, and I am with the University of Texas at El Paso. And so we recognize that the COVID-19 pandemic has presented a variety of challenges that include health, social, economic, and mental over the last few years. We also recognize that COVID-19 has disproportionately impacted communities of color in certain populations. The current pandemic amplifies existing injustices that have long been endured by certain populations. Yet, it also has provided us an opportunity to engage in creative ways and find approaches that are effective and that can be utilized post-pandemic. At the University of Texas at El Paso, we pride ourselves on being America's leading Hispanic serving university, and that the population we serve represents 21st century demographic. Over 80% of our student population are Hispanic, Latinos, Latinas, which is also reflective of our community and our region. The university recognized that as a leader in the community and being a respected entity, we had an obligation and a responsibility to respond to the COVID-19 pandemic. Therefore, starting in 2020, there were test sites organized for university faculty, staff, and students, in addition to mega testing sites, which were made available to the entire community. There was also a COVID-19 illness reporting tool that was designed so that the university could track cases, keep a surveillance system, and allowed for campus contact tracing. And then vaccinations for employees, family members, and for the general population. There are also a multitude of COVID-19 related projects to include geospatial research, assessing COVID-19 stress, coping strategies, and overall well-being, COVID-19 impact on the LGBTQ+ population, and the development of new technology. Now, the University of Texas at El Paso has been a strategic partner of the National COVID-19 Resiliency Network. Our efforts entail engaging with migrant workers and food production workers, and so that includes farm workers, dairy workers, and meatpacking workers in 3 counties, El Paso and Moore, Texas counties, and South Doña Ana, New Mexico County, and then along as to include some of the surrounding counties. As you'll see on the map, the circles and the oval on this map show you where these counties are located, and it gives you an idea of the proximity to the US-Mexico border among 2 of our counties. The counties selected are predominantly Hispanic, Latino communities with sizable numbers of food production workers and therefore highly susceptible to COVID-19. El Paso and southern Doña Ana counties are on the US-Mexico border, and they concentrate in irrigated farming with large seasonal and permanent workforces. Texas is a major sending state for migrant workers in the US. Therefore, workers may spend part of the year in Texas working in agriculture and then migrate to other states during the planting and harvest season. Migrant workers tend to travel in migratory streams depending on the weather, crop conditions, and work opportunities. There are also large dairies and plant in southern Doña Ana County. And many of the farm workers who work in Doña Ana and El Paso counties live in Ciudad Juárez, Mexico. Therefore, continuous migration between the two countries, US and Mexico. Moore County, while it's located much further from the border, it's in the Texas Panhandle area, but it also has a very large meatpacking plant and numerous irrigated farms that employ Hispanics. And so we have formed strategic, formal partnerships with community organizations that mobilize community health leaders, as to call them. So that's community workers, promotores de salud, and they're the ones that go to the fields, the dairies, the orchards, the meatpacking plants, and other strategic locations where we find our priority population. We know community health workers expected. They're frontline public health workers who are trusted and have a close understanding of the communities we are targeting, and we are maximizing their knowledge and expertise to reach our priority population. So at the early stages of the COVID-19 pandemic, a farm worker study reported on some of the major concerns farm workers were reporting. And some of those included not having the appropriate protection, low numbers of employers providing face masks, and that there was a lack of hand washing stations. Some studies show that as many as 1 in 12 cases of COVID-19 in the early stages of the pandemic in the United States have been tied to outbreaks at meatpacking plants. And in 2 of the 3 counties that we are serving, COVID-19 outbreaks have forced the plants to shut down for periods of time. Now, for the dairy industry, it was declared as an essential component of our nation's infrastructure. Therefore, dairy workers had to continue their milking operations even when there were surges of cases happening in our communities. So our project started with a much smaller scope of work, and that was to develop and disseminate culturally and linguistically appropriate information on COVID-19. But as I mentioned earlier, we learned of some of the needs of our priority population, and then we acquired and were able to distribute protective equipment. Now, for the print collateral, we developed material in English and Spanish on topics that included the proper use of face masks, why it's important to wear them, the civic responsibility, so what to do if someone around them tested or if they tested positive themselves in order to protect their coworkers and family members, and then some information on gatherings. And we wanted to address the mental health aspect with mentioning that it was okay to feel sad or upset over the pandemic circumstances, but that it was important to be patient and be respectful. So as the vaccine became available, although limited, we heard of some of the challenges our population were facing when registering for the vaccine. And that included the technology, the lack of knowledge of how to work the technology, or even the lack of access to the internet. Unfortunately, a lot of these counties had English-only enrollment forms. Therefore, what we did, equipped our community health workers with iPads and hotspots, and we provided them training on how to enroll food production workers for the vaccine. Now, as the vaccine became broadly available to the general population, we conducted focus groups to understand the barriers among our priority population. And they reported the lack of transportation to vaccination sites. Many of our workers, they reside in rural communities that don't have access to public transportation or their lack of personal transportation. They were also reporting the limited hours of operation of vaccination clinics And for many of them, missing a day of work is not an option. So with some regional partners, we have organized and hosted vaccination events at apartment complexes that are designed for our priority population. We've provided transportation to vaccination sites. We've held some of the vaccination events in the evenings, as well as in the weekends. And we've also provided some options to include drive-through and in-person so that they could bring their children. And then we got creative and started combining a social time with vaccination events to include events like pozole y vacunas. And all of these events were open to not just our priority population, but also their families, because some were reporting, I'm not going to get vaccinated until my family can too. So for me, it's important to put faces to these food production workers who have not only been working through this pandemic to put food on their tables, but really on all of ours. And so I'm taking this opportunity to share some of the images from the incredible work of our partners, our community health workers, going out to the fields, the meatpacking plants, the orchards, and the dairies. As you can see, this project has combined research, community outreach, and advocacy in farm working, meatpacking, and dairy communities, and we've been recording valuable lessons. Now, one of the statements Dr. Russ made earlier today was to let's cultivate health equity wherever you are and wherever you go. And that really resonated with me. So let's continue working together and reach the goal of having positive, long-lasting impact and health equity wherever we are and wherever we go. Thank you. Now I'll go ahead and pass on our microphone to Sheri.
Thank you so much. I'm not sure if I can follow that. That was just amazing. Thank you, Nora. Welcome, everyone. Vilino Mai Kako. I'm Sheri Daniels, and I really wanted to start my conversation with you all with just kind of centering and regrounding ourselves. I'm not sure where everybody is at across the country this morning or today, but here in Hawaii, we welcome the day with gratefulness and open hearts. So I wanted to just kind of start my conversation with that, because I think as Nora talked about, and I'm sure Silas will as well, we learned a lot of things during COVID. Some are very similar across the country and across demographics, and some are very unique to our community. So today, I come from the perspective of the Native Hawaiian and slightly Pacific Islander lens and perspective. This is really the purpose of why we're here today, and the work that we do in our communities is to uplift the voices of our Native Hawaiians and Pacific Islanders through the cultural understanding and values and beliefs that we bring to the table, which often when we work in a lot of our communities isn't always at the forefront. And we know that COVID has really propelled that and highlighted some of those disparities, not only in the health and in COVID testing and vaccinations, but it adds a bigger layer around systemic issues and challenges that some of our communities have faced and continue to face. Papa'ololokahi is the Native Hawaiian Health Board. We are a codified federal law of the Native Hawaiian Healthcare Improvement Act, and our sole responsibility in Kuleana is to uplift the health status of Native Hawaiians. And so unapologetically, that is our charge. Native Hawaiians make up about 600,000 across the United States, which in the scheme of numbers is very small. And so when we look at that, I think that's where, when we talk about resources and access to care and other challenges, that becomes a large factor. But similar to what you heard from Nora, our communities struggle with other health disparities that are played off of a lot of generational trauma and other factors that are chronic conditions led that also impacted with COVID. The generational housing situation that our families do, many of our community work in essential positions. And so all of those factors have added to the large number of Native Hawaiians and Pacific Islanders impacted by COVID. However, I do want to just kind of preface that we often focus on all these disparities, but we want to kind of change that narrative, that we become the drivers of what that narrative is. And although we recognize the disparities, that for our communities, it's really about resiliency and looking at our past to move us forward. And it's really looking at how we recognize and accept or acknowledge that we actually have some really great resiliency components, which I'll talk about briefly. So these are just some of the things that our organization does. The biggest part with COVID is we recognize that our numbers, especially in the Pacific Islander numbers, were very high. And in Hawaii, we're several months behind the continent in tracking those numbers. So in March of 2020, when this all kind of started, there was an article that came out on Pacific Islanders on the continent. And what we recognized right off the bat is NHPIs are often tagged together. But we were seeing that these numbers weren't indicative of Native Hawaiians, especially those Native Hawaiians and Pacific Islanders in Hawaii. And so we formed the Native Hawaiian and Pacific Islander Hawaii COVID response team. And this was to partner with the National Pacific Islander COVID response team. And it was really to not create a new silo, but it was to actually look across our state and across our Native Hawaiian communities and to see who else was already talking and having conversations and bringing us all together so that we could have a stronger united voice. But we also recognized that it was an opportunity for us to collect and utilize accurate data. And to have a space at the table to really establish a presence so that we could be part of the conversations, not the conversation, right? So that we could have a seat at the table. Our COVID response team actually has several pillars. We were looking at testing at that point of starting. We've grown into adding tracing, isolation, and vaccinations. And as we move forward, that pillar is going to be morphed into more of a COVID response pillar. We also knew that we were talking about recovery. What would that mean in terms of post-COVID? So we were looking at this 2 years ago around, okay, at some point as the pandemic morphs and changes and wanes at some point, what after? We knew we needed to address social support in the broader sense. We knew policy was an important thread, as well as communication, as well as data and research. And in each of these pillars, we created a structure of co-leads and committee. And this was really important because we knew that as Native Hawaiians and Pacific Islanders, we came with unique challenges and successes, but we knew that we needed to support each other. So we created a mechanism that allowed us as Native Hawaiians to have space and our Pacific Islanders to have space and come together for these larger overarching pieces. Each of these threads had goals, had priorities that we recommended to our legislators, to our Department of Health, and to other state organizations, because we knew that as a unified voice, we could help to implement and help create sustained change in our different systems. What the team also developed is, and we do have a website, and the website address is on here, but we created a place where we could put information that through our partnerships with the NCRN network and other partners, that we could house it in all one location and we could link to our other spaces. What we also provided was every week we would create this kind of dashboard so that our community and the community at large could see where Native Hawaiians as well as Pacific Islanders were in terms of case positives, as well as our vaccine summaries, as well as our hospitalizations and bed space. One of the things you'll notice, and this is for what we understand, Hawaii is the only state that has done this, is that they specifically disaggregate Native Hawaiian numbers. This was not an easy feat, and this was due to the work of our COVID team. And this was really important because early on, we recognized that Pacific Islanders were highly impacted by COVID. And we could track very specifically when exactly that shifted and Native Hawaiians became the larger population that was impacted. And so in terms of data tracking, it really proved that invaluable for us. We also were able to talk more succinctly about prioritizing vaccinations when it came to that point. We had the data, we could really show. One of the challenges that we identified with the vaccinations is that when our state was prioritizing by age groups, we were able to say that for Native Hawaiians, you're not capturing our community because the life expectancy was lower than the age in which we were prioritizing vaccinations. And that was really important. And that was through the work of the COVID team. And this is when I talked about we could actually pinpoint when Native Hawaiians surpassed in the numbers of case positives. And that was really important for us to show in our communities. I love this slide because you'll see all of the 60 plus organizations that come together and are part of this team. And what's really amazing, and which is, showing of community and how our community creates that community resiliency, is that nobody got paid. Nobody came to the table expecting anything but to truly support our communities during this period. And I think that's indicative of how communities, especially many of our communities, function even outside of a pandemic. And so when funds did come, we were able to really push out into communities so that they could do more and enhance the already great work that they were doing. And I kind of disclaim this with, even the great successes had a lot of learning and a lot of challenges. So I think, by us focusing on what really worked, helps us to identify and move forward in addressing and improving the lessons learned. One of the great outcomes of this is we were able to continually reach out beyond the Pacific, right? Beyond Hawaii, to look at how we could partner and leverage resources. And we were able to create toolkits with other partners across the United States. And this is a few of those partners that we worked with. Communications, which I know Nora talked about, is how do we message? How do we engage our communities? And we recognize language and messaging was very important, but not just language, but having resources that communities could build upon. And that was really important. So it wasn't this one shot or one attempt. It was, how do we create something that we can continue to use moving forward and beyond the pandemic? Tons of webinars. I think everybody had that experience during COVID. And then the partners. I mean, if it wasn't for partnerships and us really leveraging, we couldn't have done as much as we've done. And I think giving communities those opportunities to empower themselves were very important. And then now, how do we continue to look towards recovery? I think that's where we're all moving and pivoting to, is how do we keep our feet kind of in the COVID space, because we know that's constantly moving and changing, but how do we continue moving forward in terms of recovery and what that looks like? And with that, mahalo again, and I'm going to turn it over to Silas.
Thanks so much, Sheri. I'm going to share my screen. And I think I did that. So first of all, I'm just absolutely honored to be here today, honored to be on panel with both Sheri and Nora. Incredible work that they're doing. And I look forward to working with them and at least amplifying the work that they're doing. To Moore School of Medicine, Dr. Mack, thanks so much for the invitation to present and share the work that we do at the Institute for E-Health Equity. As introduced, I'm Silas Buchanan. I'm the CEO at the Institute for E-Health Equity. We are based in Cleveland, Ohio. We're a social impact consulting firm. E-Health Equity, as the name infers, we're frankly concerned about an exacerbation of health disparities because of technology. So we spend quite a bit of time on one side working with underserved communities and communities of color, raising their literacy around the benefits of adopting and utilizing technology to improve health outcomes of individuals, communities writ large, and families. On the other side, it's important that we work with the ideators and innovators of health tech solutions to ensure that things are being spun up in a culturally appropriate way. It's difficult sometimes to see commercials around things like continuous glucose monitoring without a person of color in it, though people of color, particularly African Americans, are disproportionately impacted by diabetes. It's pandemic in communities, but sometimes these tools, trackers, applications, and devices appear not to be spun up for us. So we spend quite a bit of time working with them as well. In a desire, however, to do less consulting, and COVID drove this for us quite a bit, to do less consulting and actually put our fingers in the dirt, right? To work closely with community, to build things to solve for improving health equity, reducing health disparities, improving health outcomes, reducing costs. We started building platforms and digging in on building, I'll say, putting together technology stacks that allow us to build world-class, geographically expandable platforms that are culturally appropriate, linguistically accurate, that allow the leaders of faith and community-based organizations that are embedded in underserved communities and communities of color, those organizations and leaders of those organizations that we all know are historically known, like, loved, and trusted by community members, to actually come together. Let's get them together. Let's keep them together in a kind of a sticky ecosystem environment, shortening the distance between them, and the community members they serve. We'll say downstream, and then upstream, shorten the distance between them and folks in the healthcare ecosystem, healthcare payers, providers, government, academic stakeholders, and the like. We know what's needed, and it is consistent access to those leaders that are embedded in our community, in our communities that are trusted by community members to actually carry the water, as it were, down to our community members. We know that the message is important, but sometimes the messenger is many times more important, and there's a disconnect there. So we started our work, frankly, in partnership with Morehouse School of Medicine, again, as seeded or prompted by COVID. We stood up ourhealthministry.com. Ourhealthministry.com, as I've described, is one of those ecosystems that we're standing up that allows the leaders of faith-based organizations to kind of come together and to stay together. The idea behind ourhealthministry.com is to help the leaders of faith-based organizations start or strengthen a health ministry. It doesn't matter if it's COVID or the next pandemic, or Ida or Katrina. When these things happen, well-meaning people descend on communities of color and underserved communities of any color, frankly, looking to help. But many times the infrastructure is not there for folks to plug into. So as opposed to just disseminating information, we thought it very important to start building things that would allow us, in this case, to help our faith-based organizations start and or strengthen their health ministry. So not only did we stand up the website, there's a full complement of social media that goes along with it that allows us to kind of cover the territory, as it were. So we have a pretty strong presence on Facebook, Twitter, Instagram, LinkedIn, just kind of across the board. We're now working to build things that are both secular and non-secular. So next up will be ourhealthycommunity.com, because again, beyond COVID, we've got to look at what made some of our communities predisposed to being disproportionately impacted by COVID, whether that is, hypertension, uncontrolled hypertension, diabetes, any of those things, obesity, social isolation, loneliness. We were set up by not taking care of ourselves or not having the access perhaps to information in a timely manner to being disproportionately impacted by COVID. And it will happen again in the next pandemic. So again, we're bent on building systems that are teaching systems. They're sticky. We want a series of best practices to emerge by shortening the distance between stakeholders. So as we continue to strengthen ourhealthministry.com, and as we stand up ourhealthycommunity.com, we'll focus on things like improving participation in clinical research. Maternal morbidity and mortality will be one of our our focus points as well. I mentioned uncontrolled hypertension and diabetes are campaigns that we will support. Very interested also in hereditary cancer detection and the like. So again, our job is to support organizations like Nora and Sheri's and all of the stakeholders that they have in their networks by offering a culturally appropriate platform that allows them to connect and communicate seamlessly and all the time, not just episodically. As we have conversations with provider organizations, and we're having some conversation now with the Cleveland Clinic. I happen to live in Cleveland. We know that they are tasked with doing community health needs assessments, as an example. And what has been a missing link has been this, very sticky community advisory board sort of platform that will allow, in this instance, leaders of community-facing organizations in and around the clinic and other places to be together and come together all the time to identify problems in our community that are persistent. There's always, or seemingly always, a disconnect in communication. So an example that was shared with me by folks at the clinic, in fact, was the community asking for the park to be fixed, and they used some of their community benefit dollars to clean up the park. And what they missed was actually the swings weren't working. There were no sliding boards. It was that sort of thing. So the platforms that we're building are designed to help improve health outcomes, but more importantly, to give our community organizations a voice as they represent our community members in ways that healthcare enterprise sometimes does not understand. So I think I'll stop there and throw it back to Dr. Mack and say thank you again. I'm grateful for the opportunity to share the work that we're doing and be on panel with Nora and Sheri.
Thank you all. Thank you all for the presentations, but also more the great work. And we have some of the INSERN team on the call, and I know they want to thank you too. And it's been great working with you all. Quickly, let's try to get a few of these questions in. And in the order that you presented, if you would answer this first question. And Sheri, you talked about unique challenges and successes, and each of you touched on that. Can you please share the unique cultural impact and challenges that you saw? It doesn't have to just be around COVID, but we know each one of our communities we have similarities, but we have differences. Can you kind of share some of the challenges that you thought were unique to your communities that you served? And Nora, you can go ahead and go first with them.
Sure thing. So what a wonderful question. And, as we started our project, we were very deliberate of ensuring that we were developing culturally and linguistically appropriate information. But once we started to distribute the information, we were made aware of different pockets of populations that perhaps didn't necessarily speak Spanish or English. And so it's developing material for those type of populations. So including indigenous for America, and ensuring that our community health workers were also prepared to have communication with that population. And so we've developed that we record, and then they're able to deliver a message to the population.
Thank you. Sheri?
Well, I think for us, one of the big challenges culturally is how we celebrate. So, for Native Hawaiians and Pacific Islanders, milestones are huge celebrations. Funerals are huge gathering spaces for our communities to come together and celebrate. And so we really had to look at how do we adjust some of those practices of gathering, which was really hard because, to tell a Native Hawaiian family that we can't celebrate your baby's their first luau, that's huge. Or how do you tell the families, no, we're not gathering for graduations? So it was really about not just the messaging, but starting to look at cultural practices and how COVID or these ways of coming together needed to be adjusted and making it okay, because for a lot of our elders and our kupunas, that was a really hard adjustment. Is, well, there goes all of our coming togethers. Culturally, we greet each other with a honi, with a kiss and a hug. That is cultural practice, and we couldn't do that. And so how do we normalize this new norm, I guess? And also too, you know, in terms of how we message safety for our communities about protecting our kupuna, protecting our treasures. That's really what's important in how we message. And similar to Nora, it wasn't about the linguistics of messaging that we recognize, but it was the visualization of the message. So when we created messaging, we had to look at how it was presented visually for our community, because if it didn't look like us, if the way it was developed didn't feel like us, it didn't resonate. And then also looking at culturally using our history as also a motivator for our communities to engage. And so I think those were really unique aspects, as well as, you know, there is this thing about Hawaiian time where we're often not as like rushed. And we also saw that in our Pacific Islanders. Not that we're not, it's not important, not that we don't see the need and the urgency, but we're not as quick. And so using some of that and understanding that it may take just a little bit longer for us to move and see change, and that's okay. I don't think we can blanket what is one community is doing from our community, and to really be okay with that. So I think those were some of the unique pieces for us.
Yeah.
Thank you.
Yeah. So for us, you know, trust or lack thereof continues to be a challenge, right? And COVID, it really pointed up the level of distrust that still exists of the healthcare system in communities of color. You know, well, specifically the communities that I work in. You know, the messages were a little bit mixed. As I stated in my overview, the message is important, but many times the messenger is more important, right? And so I may not trust what my physician has to say. I may trust what my pastor has to say more than my physician. You know, if you are a faith-filled person and relatively healthy, you know, you'll spend, you know, probably 20 minutes a year at your physician's office doing your annual physical, but you'll spend 70 hours a year in church. So, you know, we've got to empower these messengers, again, that are known, like, loved, and trusted by community members with the messaging to deliver. It will be more well received. And so that tended to be a challenge. And I'll say I'm thankful for Morehouse School of Medicine, NCPC, and the work that you guys did around COVID, frankly, because it became a bit of a North Star that we could begin to grab and push to these trusted messengers that folks were actually are and still able to glom onto and hold on to know, hey, this is coming from an HBCU academic institution, and I will carry this. And we know that is coming maybe from CDC, but the fact that we're able to wield the name of Morehouse School of Medicine in our messaging, it means a lot, and maybe more than you guys know, frankly.
Well, thank you, Silas, and thank you for the compliment. We really appreciate that.
It's true.
I hope so. Thank you, sir. Quickly, and then we want to get to solutions. Can you all please comment on the state of health within your community? Going back to, you probably heard me say this, for the pandemic of 1918, our communities had the worst state of health before, during, and even worse state of health after, because of the disparities and the way programs were implemented. Can you comment on the primary care and prevention, the state within your community, the gap that may be after COVID, now and after COVID? Just want to hear your comments on that. Let's start with you, Silas.
Okay, and I'll be brief, but so COVID, in addition to folks like us that attended way too many Zoom conferences and meetings, right? It did allow healthcare providers to be compensated for visits, okay, electronically. And so you can't put that toothpaste back in the tube, and that's a very good thing. I'm fortunate that I do sit with I'm affiliated obviously with the work that Morehouse is doing, but also I sit with the American Telemedicine Association and their CEO Roundtable on Diversity, Equity, Inclusion, the Digital Medicine Society, as well as Milken Institute Faster Cures. And in these rooms, right, we talk about the technology that's emerging, right, and what could be adopted, and how we make these things more inclusive and less exclusive. And I think that because well, obviously prior to COVID, there were no telehealth or telemedicine visits. Our faith-based organizations were shut down. And so a lot of the conversations that we're having now are, how do faith-based organizations open? Are they reopening? Should they reopen? How do they reopen? But they were already aging out to a degree, and they've lost membership as a result of COVID. And so after COVID, right, to answer your question, so before COVID, it was one thing. After COVID, some of the problems are worse when we talk about who's trusted in community. So technology, I think, can help that, right? If we can now maybe put telemedicine outposts in our faith-based organization, it makes our faith-based leaders and organizations more relevant at the community level. If they could carve a small space in their faith-based organization for folks to have a private consult, to say, hey, doc, look, I've got a mole right here, that sort of thing. It may help them to open faster, to grow their membership, but also to improve health outcomes. So I'm optimistic, post-COVID around the adoption of technology to improve health outcomes in our community. So I'll stop there.
Thank you. And quickly, seems like we almost at time, but go ahead, Sheri.
I think, okay, so mine is kind of like Silas, but I'm gonna just, I think, be blunt about this. What we recognize, and I agree with Silas 100%, there's so much potential in many, many areas. But when I look at the systems and the resource holders, i.e. often state governments, it's almost like they're going back, they're starting to revert back to pre-COVID behavior in how they engage with communities. And I think our communities have learned that, oh, no, there's a different pathway we can take, that we should be taking. Like, we should be more at the table and driving the bus. But I don't think our systems, unfortunately, are as nimble as communities are. And I think it's easier for them to almost do what they're comfortable and what they've done status quo. And we're seeing that. And I think what we're going to see at some point is this kind of budding between community and systems, i.e. funders, i.e. government, around what really works for them, because status quo is no longer acceptable. And I think that's what we're starting to see kind of go back to that pre-COVID behavior. And that concerns me because, kind of like what Silas says, there's so much potential. There's all these things that we can grab on, we can cling onto, and opportunities. And it's almost like going backwards. So that's where I'm going to leave it at. Food for thought.
Nora?
Oh, I love that we're ending this session with a message of hope. In El Paso, we were one of the hotspots in late 2020. Where we were having very large number of COVID cases and even mobile morgues outside of the hospitals. But now we're one of the counties with the highest vaccination rates. And I think that speaks to the collaboration and support and having many organizations work together to ensure that we are working to mitigate the impact, that we're working collaboratively so that we're maximizing our resources, we're not duplicating efforts, and that we are sharing a cohesive and collective message of let's continue to utilize those protective measures so that we're not only protecting ourselves, but also our family members and our community. So, with that, I think both what Sheri and Silas shared gives us much hope of some direction, and how do we continue to work together and collaboratively in future projects and opportunities.
Thank you all so much. Dominic, you can close it out.
Yeah, I was saying Nora took my job. She closed it out for me. But Nora, Sheri, Silas, you presented solutions in your presentations. Not enough time, but thank you all so much. Thank you.